I became far more interested in people than diseases. I became interested in the whole holistic sense of caring, and that people weren't just diseases on legs. General practice did, to some degree, chew me up and spit me out, in that it became all-consuming, because that relationship was so fundamental, I thought, to the whole thing. Unless you get close to people, you don't get near the problems. But the closer you get to people, the more pain you absorb. Forgive me, because it does become a bit emotional. Because these people were my friends. They weren't just people with illnesses. I'm Dr. Dan Muckle-Jones. I still use the title doctor. I'm allowed to do that even though I'm retired. It's something I worked for, so I like to keep using it. And I'm known locally as Dr. Dan. I was a GP in mould for nearly 30 years, and it was a very big part of my life, obviously. I retired for a variety of reasons, but I was ready to retire, was the bottom line. I did enjoy it, and the truth is I miss it. I don't miss all the pressure, but I really miss the people. Every consultation is a building block in that person's relationship with me and my relationship with them. And general practice is about relationship. It's about trust. If somebody can realize that they can trust you with a minor thing, they will trust you with something more important. And it was not uncommon that people would come and almost test you, not knowing, not consciously, but they would come with something that might be, relatively minor. And their hand would be on the door handle going out and about to leave the door when they would suddenly turn around and say, "While I'm here, doctor, what do you think about this?" And the number of times that was actually the most important thing and the thing that really needed attention. And then revealing that to you was because they trusted you enough to do it. General practice is about the art of medicine as much as the science. The art of applying the science, but also the art of interpersonal relationships, about being somewhat plastic. It's about establishing rapport, being lots of things to lots of different people, but at the same time being sincere, genuine.
Working on the rare disease side, and I have a child with a rare disease, one of the things that we've found is the importance of partnership working. And I can imagine that when it comes to end-of-life care in particular, that partnership is really important. Do you think that in your experience as a GP that you found those relationships to be really important?
You would not believe the number of prescriptions that don't get dispensed, the number of medications that don't get taken, yeah? And that's a lot of waste. The number of courses of drugs that are not completed. Yeah, why should somebody do as they're told, They will willingly do the same thing that we've decided is a good thing if we have the basis of trust to believe that I'm actually giving you good advice. That's the thing, isn't it? So you have a rare condition, say. My job as GP would be to really say, look, in the early days it may be crumbs, we've got a problem here, we're going to have to deal with this. Not only is it rare, we're going to have to deal with it maybe for a long time, okay? I don't know, I'm not an expert in this, but what I will do is I will read up on it and I'll get, we will become experts in this disease together, yeah? What we will do is we will make sure we know who to ask for advice. What we will do is we will make sure that we communicate with the people who are managing this disease in a way where I will try and negotiate the system with you, help you understand what's going on, and I'll learn about this with you on the way. It'll be a joint journey, yeah? And I learned a lot from my patients. And it's that sort of intensity of relationship that can be, incredibly draining, but incredibly rewarding. Incredibly rewarding. But the job of a general practitioner is also to recognize that you do not have infinite resources.
What sort of difficulties do you face, or did you face in your role?
Obviously, not every patient that you meet who has end-of-life issues, it could be that they've just moved to the area. So I might not have the same, it might be that I'm building up a relationship then, but in many cases, it was very applicable what I was talking about, that building of trust over years in a relationship. In many cases, I would have that relationship with somebody. And the difficulties are, first of all, here's somebody who I know and I have a relationship with, now in a situation where we know that they're going to die. And that is, emotional. So we have to have an element of objectivity and whatever else, professionalism, so that they don't think that this is just a mushy relationship. That actually, no, I've got a relationship of trust, but this person can help me. Not only is every person different, but every cancer is different. Not all terminal illnesses are cancers, but cancers are different. And I think part of the importance of the medical training and the continuing education and the learning is to know what particular sets of problems a particular cancer might present. And then knowing what the tools in the toolbox are to deal with those, and knowing who can help.
With our own experience, we found that there was an over-reliance on the use of morphine, and that's quite difficult if that isn't doing the job. And do you think it's important that, firstly, that you're having this relationship with patients where you can talk about different things, but also it's important that there isn't an over-reliance on one type of drug fits all?
I think this is where it's so important to work as a team in palliative care. And the GPs, we have a really important role in helping to coordinate services. In some ways, that's one of our most important roles. Is we're not consultants, we're not specialists. We have to recognise the limits of our own competence and abilities, and sometimes that involves a little bit of setting our egos aside and saying, actually, this nurse might know more about this than I do. To at least have a discussion with the local palliative care team, even if it's just to flag them up and say, look, we've got this patient with this, we may need this, that, or the other. Also, things like having a just-in-case box in a house. So, maybe somebody doesn't need morphine and antiemetics and anti-nausea drugs at that time, but you knew that they soon would. So you would have those in a little toolbox in the house for when they did need them, as they inevitably would.
I would imagine, and I know from my own experience, that that aspect of trust is really important, especially when you're coming on that journey with them. How important have you found the element of needing that trust from the families?
Well, I think it's extremely important because, not least because you will be there after they've gone, trying to help the family deal with it, and it's going to be painful. It's going to be sad. So, I'm not saying that GPs are the only thing that deal with bereavement. The only modality for that. But I think that general practitioners have an incredibly important role to play in helping people with bereavement, recognising the loss and that it's horrible, that it's painful, and that GPs have an incredible responsibility in not over-medicalising bereavement, signposting people to services like CRUISE, and where relevant, the spiritual aspects are important as well.
By spirituality, do you mean faith, or is it more than that?
Not any specific religion, but people have different understandings of what death is. Yeah. Whether there is some sort of afterlife or not. My experience was that patients who had some structured belief system about what happens after death, and families that shared that often coped with bereavement better.
One of the things that we've been asking people, especially around the end of life care, is what matters most when it comes to the end of somebody's life?
For me, the most important thing was to be able to come out of that situation thinking, yeah, we did that well. That was the most important thing. Just to think, yes, we did our best for that person. And for me, that was about getting all the people who could make that death better and more somehow palatable, to get them all firing in tune, and that patient's wishes had been respected.
In a way, I think the role of a GP is almost like a role of a conductor.
Yeah, absolutely. An orchestra. You have an orchestra at your command, and you've got to know what the instruments are. You've got to know what tools are in the toolbox.
So we've talked about you having this relationship with your patients in the sense that you've been there for a long time with them. Maybe sometimes you've even been there when they've been born. How do you cope personally with those difficult discussions around, the fact that somebody's end of life, but also how do you cope after, and also in terms of supporting the families?
The first thing I would say is that I used to consider it an incredible honour that somebody would have me there. It's an incredible honour that someone would be willing to put their trust in you, and in such a sensitive and personal time, to be at someone's, with them on that journey. And I think also it was actually quite important not to be too obtrusive as well, remembering and respecting that actually the family are more important than you, yeah, and that they need time together without you. So yeah, great honour, often very emotional, trying to not show too much of that emotion, because you part of the trust in you as a doctor is trusting your objectivity and professionalism, but inevitably it's at a personal cost. But you need to temper that with humility and remember, yeah, it's not about you. Yeah, it's not about you as a doctor. It's about them.